good afternoon, or to some of you, good morning, and welcome. On behalf of MIDAS Healthcare Solutions and Fresenius Kabi, thank you for joining us for today's educational webinar. My name is Jeff Wall, your host for today's session. I am co-founder of and general counsel for MIDAS Healthcare Solutions. For almost 40 years, I've been a medical risk management and patient safety attorney, and I've handled many high-profile investigations and diversion litigation. I frequently lecture at hospitals, medical schools, and healthcare organizations on a variety of topics, including risk management and medication diversion. For the past 10 years, I've concentrated on perioperative safety, have authored a chapter in the last 3 editions of the leading pediatric anesthesia text, and have been an editorial reviewer for the world's most respected peer-reviewed anesthesia journal. I also am on the visiting faculty in the Department of Anesthesia at Children's Hospital of UPMC in Pittsburgh. Today's webinar focuses on one of the most overlooked aspects of diversion prevention, waste. We'll explore how hospitals can move beyond reactive audits toward proactive prevention by combining product design, inventory optimization, and tech-driven verification to eliminate blind spots in the controlled substance waste process. And just to set your expectations, this will not be a product pitch. This will purely be educational. We're here to share lessons learned, real-world insights, and strategies that can strengthen safety and compliance across your organization. Joining me today are 2 experts who live and breathe this work. First, we have Marilyn Wong, Director of Integrated Pharmacy Services at Fresenius Kabi. Marilyn is a board-certified pharmacotherapy specialist pharmacist with extensive experience in hospital pharmacy leadership and operations. She currently is the Director of Integrated Pharmacy Solutions at Fresenius Kabi USA, where she works with healthcare professionals to identify product optimization opportunities for ready-to-administer products to enhance medication safety and operational efficiency. Prior to joining Fresenius Kabi, Marilyn served as a director of pharmacy with Advocate Health and previously held leadership roles in multiple hospitals here in Ohio and Kentucky, where she led teams of pharmacists and technicians, ensured regulatory compliance, implemented cost savings initiatives, and improved patient safety. Along with Marilyn is my colleague, Adam Beeler, a pharmacist and expert in drug diversion prevention and regulatory compliance. Adam is Vice President of Strategy at MIDAS Healthcare Solutions, supporting health systems in building structured, enterprise-wide diversion programs. Previously, Adam was Director of Pharmacy Services at Fresenius and was System Manager of Controlled Substance Compliance at the University of Kansas Health System, where he focused on advancing standardized, defensible approaches to diversion detection and investigation. Welcome, Marilyn and Adam. Adam, let's start things off with you. From your time leading diversion prevention efforts at the system level, how are hospitals managing diversion risks today?
Thanks, Jeff. And before we get started, just so everyone's not seeing the complete gallery, which might be a little distracting, click on the 3 bubbles where it says more. Just do me a favor and do this. It takes 20 seconds. Click on that. If we go down to view, change it from gallery mode to speaker mode. On our end, we can't change it, but that way we'll focus on the speaker of who's talking. So with that said, thanks, Jeff. Thank you for the introduction. And I'll just reiterate the questions just so we can get back on track here. So Jeff, you asked, how are hospitals currently managing diversion risk today? And before I dive into that, I just want to kind of give a quick detour into my past experiences because it kind of speaks to why I can even speak to this today. So, prior to my role here at MIDAS, I was a system manager of controlled substance compliance at KU. Integrated AI technology really set the framework for how that system still operates today in some capacity. From there, I was director of pharmacy services at Fresenius, where I was fortunate enough to work with a lot of different health systems and see how people are approaching drug diversion from all different angles. And through those insights, and I promise I'm getting to your answer here. Through those insights, I've seen an evolution of drug diversion, and so it's important to go back and take a little history lesson before we talk about where we are today. So it wasn't that long ago, 90s, 2000s, we were implementing ADCs, automated dispensing cabinets, but even prior to that, we just had stock bottles on the shelf. We had manual documentation. It was really easy to steal drugs. rightfully so, because you could just write down on a manual log what you took or didn't take, and that was it. We got ADCs installed, and now we had these things called discrepancies, right? Where the system could automate and tell us how much inventory was supposed to actually be present. And so diverters were taking two instead of taking one and diverting that way. And we kind of caught on to that, right? We had reports, we had things in place. Automation certainly helped with that. The digital audit trail certainly helped with that. And so the next evolution as to where diverters went was to steal waste or the amounts not given to patients, or let's say they took a full dose of a 2 ml vial, they administer 0.5. That rest, we had a hard time trying to reconcile that. And so a lot of programs that I see today in the industry are still working on that reconciliation piece, rightfully so. The DEA asks us to do that. But my fear and what I think we're in next is already the next era of drug diversion. And what I mean by that is diverters are smart. We have AI analytics, diversion softwares are kind of the mainstay now in the industry. And so we have to look beyond that, right? If diverters know that we have technology to essentially identify where drugs are not reconciled, they have to do something else. And so you see this movement with my hands. Guys, we're moving closer to the bedside, and the era we're in now is the era of falsified and misdocumentation, saying that you did something but not actually doing it, whether that's disposal of waste, whether that's administration. And my big fear of that is, what that means for our patients. So how are hospitals currently managing it today? Well, by and large, there's kind of three buckets that I see this, and we could have a long debate. Jeff, I could talk hours about this in itself, but if we put it in three buckets, I put it in a prevention bucket, a monitoring bucket, and a compliance bucket. So by and large, what these programs are doing, what we're doing, what the audience is doing is, from a prevention standpoint, we're talking about security and physical barriers, right? What type of automation do we have in place to prevent just the random passerby of actually grabbing drugs off the shelf, right? We're talking about, and the DEA has regulations around, some of those security barriers that we need in place, but it's that physical separation between people and drug. And then to help on the back end of that, we need policies in place to also hold folks accountable to when that gap is minimized, or for by and large, it's when nurses have to interact with drugs, pharmacists have to interact with drugs, right? So there's prevention from a monitoring perspective. By and large, hospitals are trying to audit and surveil for drug diversion. What I mean by that is auditing could, it's I hate to say this term, we're all pharmacists, or a lot of us are on this call, bean counting, right? It's making sure our balance sheet at the end of the day is zeroed out. Whatever we get into our pharmacy in our hospital is what was also dispensed, and everything's accounted for. When I talk about audits, guys, that's really what I'm referring to, is like, what reports, what things do I need to do day in, day out to make sure that there's not large scale diversion happening? And then surveillance is your monitoring of ongoing activity. That's kind of the more behaviors of end users, our nurses, our pharmacists, anesthesiologists, et cetera, of what are those data analytics, what are those cues that we're capturing, and how are we identifying risk of where diversion might be, and then how are we actually finding drug diversion? And then the last piece there, Jeff, how programs are currently managing drug diversion today is from a compliance perspective. So I always distill this down to the 3 R's: registration, record keeping, and reporting. Obviously, we need to be registered with the DEA. We need to make sure across our enterprises all of that's squared away, and we have all of that documented, and it's all correct, by the way. Record keeping, short phrase, there's a lot to unpack here. Not enough for this particular call, but we could certainly have future webinars that just talk about this alone. It's everything from your orders to your dispenses to your disposal, but also think about record keeping as in terms of how you're actually doing your investigations as well. DEA is going to want to know that, right? And then the last one is reporting. So reporting theft and loss via 106s, doing your biannual inventory reports, and then any significant loss with a Form 41. So by and large, prevention, monitoring, compliance are how programs are really managing this today.
Adam, it's a terrific way to start off this important session. Marilyn, we're going to toss it to you. Now, you've worked across hospitals, with dedicated diversion teams and remarkably hospitals without dedicated diversion teams. What do you see in terms of how health systems are currently approaching diversion risk?
Yeah, so during my time as a pharmacy manager and director, I have worked as health systems without a dedicated diversion team, meaning the diversion response team is made up of a variety of pharmacy, nursing, and hospital leaders. And I've also worked at health systems with a dedicated diversion team. Regardless of the structure, the diversion team is typically activated upon report of suspicious activity or behavior, or if the diversion software flags unusual transactions for review and we're unable to reconcile for the controlled substance dose. All of the work are reactive in nature, such as following up on undocumented waste, improper waste and documentation, delay in time to waste, which all pose a diversion and compliance risk to the organization.
Terrific. We're going to move to the broader risk landscape. If you talk to any diversion prevention team member, they will undoubtedly tell you that waste is where things often fall apart. It's messy, it's manual, and it's easy to overlook. But that's exactly why it's so risky. Waste disposal is often the easiest and the least visible place for controlled substances to be diverted. So as we dive into this next part of our conversation, let's take a closer look at the risks tied to unmanaged drug waste, not just from a compliance standpoint, but also how that impacts medication safety, patient care, and even staff well-being. Marilyn and Adam, before we get into the hows of managing controlled substance waste, let's take a moment and talk about the whys. Why is unmanaged waste such a high-risk area? Marilyn, let's start with you.
Sure thing. So three things comes to mind. The first thing is drug diversion. Waste creates diversion opportunities. Not saying every time there's a waste, there's a diversion, but it does open up an opportunity. This is a major risk for hospitals, and especially for hospitals manually managing procedural rooms and any offsite surgery centers waste. Second thing comes to mind, compliance risk. We're talking about DEA, Board of Pharmacy, Joint Commission scrutiny. If DEA shows up at your hospital, they randomly pick a controlled substance, any of the C2, and ask you to readily provide the entire record keeping going back past 2 years on that drug. Do you have everything, every single transaction, right? Third thing comes to mind is medication safety. There are errors when handling partial doses. And then also there's risk of unlabeled or mislabeled drug errors. Adam, how about you?
You know, I think that's the right place to start, Maryland. And I'll add really two buckets, and bear with me, everyone. The first bucket is patient safety, and this is probably pretty obvious to everyone. But the second is also employee safety. I don't want to forget that, and I'm going to come back to employee safety. But let's start with patient safety and what that means from a risk perspective. Drug tampering, adulteration, drug swapping. This is what I mean by patient safety, and in particular with drug waste or drug diversion altogether. I've been a part of these cases. I've investigated these cases in which adulteration or swapping has occurred. And just everyone, if you're wearing a button-down shirt, just look at that white button. It's 6 millimeters in diameter. That's about the size of an oxycodone tablet. There's probably 50 drugs in your ADC right now that are small, round, in between 5 and 8 millimeters in diameter. So when we talk about swapping, what effect does this actually have in a patient? Well, swapping from just a pill perspective could mean, drug interactions, allergic reactions, drug side effects. I've seen this in neuro ICUs, and all of a sudden a patient's getting a blood pressure medication when we're trying to really stabilize that blood pressure. Swapping can also cause undue suffering from a pain management perspective. But then also when we talk about, waste and swapping waste in particular, whether that's with normal saline or an actual, other drug, a lot of times those needles are not clean. A lot of times that process is not clean. So now we're introducing opportunities for infections. And so as you can imagine, all of that impact from a patient safety perspective is incredibly scary. And a lot of that relates to drug waste in particular. The other kind of side of that coin, still speaking to patient safety, is impaired providers. Again, we understand that substance use disorder is a disorder. We're not placing blame on anyone, but when you are under the influence in a workplace and you're not thinking in your right mind, that's when you're not making logical decisions, and that can have real consequence for our patients. So from a patient safety perspective, those are the two biggies. From an employee safety perspective, it's really staff being exposed to hazardous drugs or unsecured narcotics. And addiction, I kind of hit on. It's not just addiction of that person, but if we really think about what puts us at a predisposition, healthcare workers, I mean, at a predisposition, we're in high stress environments, life or death situations. A lot of times it's emotionally overwhelming. We have incredibly easy access to drugs. And again, we are intelligent people. Like, these are highly trained, highly sophisticated people. These are nurses, doctors, pharmacists, CRNAs, and they not only know what drugs they want to get the effect they want, but they know also how to do it without getting caught, because they're part of the operations on a day-to-day. Obviously addiction can lead to long-term consequences. The other one, from a employee safety perspective, we often don't think about, especially as it relates to waste in waste processes. Even diversion aside, just for a moment, let's just go down this thought pattern of anytime we are disposing of waste, most of the time, and you can go to your videos if you have access to them, a lot of times that needle tip is still on there. And I found a stat that said that 99% of residents have at least one needle stick injury during their residency training, which means they're going through that whole process of having to get tested, maybe having to get treated for bloodborne pathogens, et cetera, et cetera. So needle stick infections, let's not forget about that in the wasting process, and the burden that comes around that. And then the other part of that too is, when we carry around waste, there's a lot of concern there too, right? It could be in the wrong hands. We could take that home. It could get, into our pets and children, and et cetera. So again, there's a lot of patient safety, employee safety there too. The last thing I'll say here before I kick it back to Jeff is, think about this from a culture perspective. When we think about drug diversion and waste in particular, all the impacts Marilyn mentioned, all the impacts I just mentioned, this is really degrading your workplace culture. You're compromising morale. You have heightened emotions leading to confrontation, which can escalate into workplace violence. Unfortunately, I've seen that firsthand. But just think about, like, this is not just a diversion event. This is a cultural event that sends ripples through your organization.
Adam, those are really sobering facts and statistics and really powerful examples. They really underscore how waste risk doesn't just affect compliance. And as you just said, it ripples across staff, their patients, and the entire organization's culture. And we want to explore that a bit further. So Marilyn, what are the biggest blind spots that health systems face when it comes to today's waste-related risks?
One of the biggest blind spots on controlled substance waste is lack of proof on proper waste process. This encompasses the lack of proper waste witnessing and documentation, lack of oversight to ensure every waste was wasted properly in a timely manner, and the lack of proof on what is actually being wasted. For example, there have been many times during my review or audits of mismatched controlled substance waste, when I reached out to the waste witness to gather information, they informed me they can't recall the details because they were busy, and they simply put down their fingerprint to serve as the waste witness.
Yeah, no, Marilyn. And unfortunately, I've seen that a lot too. I think a lot of people on this call can attest to that being almost a normal practice, unfortunately. And so, just to piggyback off of what you're saying there, I think, again, we think about blind spots that we see today. I think one of the big ones is a false sense of control that many organizations have around waste. So, on paper, you have policies, the dual witnessing, you have EHR workflows in place, but in practice, waste really remains one of those least verifiable and most inconsistently managed parts of that medication use process. And so, again, Marilyn, as you alluded to, the riskiest blind spot is that lack of verifiable proof, right? So hospitals often can't truly verify what was wasted, by who, by when, under what conditions. And so, even those hospitals that are fortunate enough to have security cameras, you may be able to verify that something was wasted and that a witness was present, but you actually have no clue of what's being disposed of, even if it's documented as being wasted. The other one that I'll mention there is oversight fragmentation. What I mean by that is, pharmacy, nursing, anesthesia, compliance, risk, HR, safety teams, everyone involved in drug diversion events, they all have a stake in the medication use life cycle, whether you truly believe that or not, including waste disposal. But there truly is a lack of unified accountability in that structure when we talk about waste disposal. And so this is where perception replaces evidence and that risk begins to creep in around the waste process. And I joke with my team, it's a lot like the Spider-Man meme of like all the Spider-Mans in a circle, everyone pointing at each other, like pharmacy's pointing to nursing, nursing's pointing to anesthesia, anesthesia's pointing back to pharmacy, and everyone's involved in the waste process and the follow-up. But really, who owns the accountability from a drug waste perspective? Sure, like pharmacy can bear the burden, but like, what does that mean for anesthesia? What does that mean for nursing if we're not holding up accountable to doing the waste process like they're supposed to be doing, right? And so that's exactly where risk begins to creep in. It's that gap between those responsibilities. The other thing I think about here is a cultural blind spot. What I mean by that, this is more the human element. So we often rely on manual witnessing in those high pressure, time sensitive environments, like in OR or procedural area. So, oftentimes we are replacing workflow efficiency. And this is this on our healthcare workers. This is just saying we are so overburdened that we are replacing efficiency of just like get it done over the accuracy of what actually is being disposed of. And so that's where both diversion risk and safety risks begin to creep in. The last thing I'll mention, and maybe most importantly on this that I was thinking about, is visibility bias. So, leadership often assumes that because diversion detection software is flagging fewer anomalies, that the problem's under control. But in reality, what's missing are those events that never get documented or are falsely documented altogether, right? So unrecorded waste, undocumented returns, partial doses that bypass the system entirely, those silent gaps, in my opinion, are where true risk lives.
So to distill what you just said, Adam, we have to rely on a comic book hero to realize how big a problem this is. So we're going to talk about the first lever, which is smarter inventory management. You've now painted a clear picture of how things can go wrong. For healthcare leaders joining us online today, where's the best place to start closing these gaps? Policy, process, technology, or culture? Marilyn?
I think this depends on the organization and where their programs gaps exist. But I think the best way to approach this problem and begin closing the gaps is to evaluate your site's current state and prioritize where to begin. Diversion prevention is a multi-pronged approach. You need policy, processes, technology, and culture to all be part of the solution. If you have policy, processes, technology, and culture in place, then I recommend leveraging inventory-related data to understand med usage. Why? Because to prevent drug diversion, you need to know where these drugs are being used and where drug waste is being generated.
Now, you mentioned leveraging inventory data to better understand medication usage. Building on that, what strategies have you seen work well around optimizing doses and product packaging to help hospitals reduce waste right at its source?
From a dose optimization standpoint, I have seen major waste reduction successes in hospitals that have analyzed their controlled substance waste activities, matching what they administer to patients to a commercially available lower strength presentations to eliminate or reduce their waste. This is a proactive approach to reduce waste and diversion risk. Dose optimization also brought efficiencies to the diversion team, pharmacy, and nursing team, because if there is no waste, there is fewer waste data feeding into the diversion software for analysis and less chance for improper waste incorrect or missing waste documentation for pharmacy and nursing team to follow up on. From a product packaging standpoint, there are many primary literatures out there that have compared the medication administration and preparation errors between a ready-to-administer, or sometimes known as RTA syringes, versus traditional vial and syringe, including Carpuject systems, and found a statistically significant difference that RTA syringes had a 4 times lower error rates than the other delivery systems. Aside from a medication safety standpoint, when a product has enhanced tamper-evident packaging and provided in a RTA syringe, it can help deter some of the diversion activities by making it more difficult to divert the drug. From my conversation with a couple former DEA agents, I was informed that by providing controlled substances in a ready-to-administer syringes with diversion deterrent packaging, combined with the proactive dose optimization approach, it can serve as a method of effective control in managing diversion risk.
It's very interesting. From a diversion prevention perspective, Marilyn, how does smarter inventory management shift the risk equation?
When we think of inventory management, we typically think of par level adjustments. I have seen pharmacies or regulatory agencies recommend stocking lower par levels of injectable control substances as a method to decrease diversion risk. However, to decrease the diversion risk, it is not solely based on keeping a lower par level, as it is more important to stock the appropriate par level, matching the patient care unit usage. Another effective inventory management method is product size optimization. This means stock the most appropriate strength of controlled substances, aligning with patient care at each care unit, instead of stocking higher strength of controlled substances that lead to waste activities.
Marilyn, we're going to keep it with you. What challenges do hospitals typically face when they try to adjust their inventory practices, and how have you seen them overcome those barriers?
Some challenges I've seen from working with different hospitals on adjusting their inventory practices to reduce diversion risk priorities are priorities, communications, or education with the impacted users, such as nurses and anesthesia staff, storage, and cost. So let's dig a little bit into priorities. We understand everyone is busy, and it's usual to be managing multiple projects and issues at the same time. However, diversion is something we want to stay ahead of, not react to after an incident has happened. I treat diversion prevention on the priority list similar to other regulatory compliance needs. If you find it to be a challenge to take on such project on your own, one way to drive the necessary inventory practice changes to reduce the diversion risk is start by engaging the right leadership key stakeholders. This can be the director or VP of pharmacy, leadership on the diversion committee, get an executive sponsor to help champion or support such project. Second thing, communication. Advanced communication and transparency help to drive success. By talking through with the impacted users, such as nurses and anesthesia staff, on the changes that you intend to make, the why behind it, which could be workflow efficiency, waste diversion reduction, etc., and getting their support from the beginning can help drive successful implementation. Also important to communicate with your pharmacy automation team and plan for any ADC or EHR bill needs prior to go live. Third thing is storage. Work with your pharmacy team or maybe the manufacturer to determine storage fits. I know at Fresenius Kabi, we offer a fit storage guide that is very pharmacy user friendly to clearly convey how many doses can fit in various sizes of ADC pockets. And then cost. Work with your contracting team and your sales rep to understand the cost. Keep in mind that rebates are typically not reflected in the listing price. During my time as a pharmacy leader, these drugs were never the top of my 80/20 drug expense report, which is the report I review monthly to see what are the top 20% drugs making up 80% of my monthly spend. Safety and compliance should take higher priority over minor cost differences, because if we deprioritize safety and compliance, hospital could face future financial penalties if patient harm or non-compliance are found.
Adam, let's bring you into this part of the discussion. Once an
Sure.
organization makes improvements on the inventory side, what's the next step that they can undertake to strengthen accountability and visibility?
Yes, it's a great question, Jeff. And let me just be clear with the audience here. Inventory optimization is not a one and done. This should be an ongoing effort. Think of that as like the left side of the equation, and it should be deployed in tandem with strengthening accountability and drug waste visibility from the other side. So now you're pushing this paradigm from both directions to really have a solid solution in place.
Terrific. Now we're going to pivot to lever number 2, technology as a safety net for a hospital. That's a perfect segue, what you just both talked about, into the next portion of this discussion. So let's talk about leveraging technology. A major driver of diversion risk is the absence of verifiable accountability.
Yeah.
When waste is disposed of without clear evidence, hospitals face blind spots where diversion can occur, compliance gaps impair audits, and safety culture erodes when accountability is weak.
Yeah.
One used to say, if you worked in a hospital, if you didn't write it down or you didn't chart it, it wasn't actually done. Well, I'm going to give you another lawyer level equation to remember. No evidence plus no proof equals no case. But technology can change that. With the right tools, hospitals can create verifiable evidence of waste events, establish real-time documented chain of custody, and even use AI to detect suspicious activity patterns before they escalate. Now, Adam, when we talk about the risk of diversion, drug waste often becomes the most vulnerable part in the process. How does technology help hospitals secure and verify the waste disposal so it doesn't become an opportunity for diversion?
Yeah, Jeff, again, great question. I think for hospitals, drug waste has always been really like an honor system. We've always handled it that way, to say, oh, I wasted it, right? Oh, I just forgot to document. And sure, that might be true. I'm not claiming people are dishonest just to be dishonest. But that's where the risk really starts to creep in, because the process itself offers no real proof in how a lot of us are handling this today. And so how I see technology really doing this is really flipping that dynamic. And so we need to turn a trust-based process, just like you said, into a proof-based one, right? Instead of two clinicians just claiming, oh yeah, I saw that being wasted, and maybe having some cameras overhead to see if they even did a flyby or not. Well, we need systems that are creating irrefutable evidence, whether that's time stamping, that's verifying what was actually wasted, and that's storing all of that information for compliance review. And so we know that being a witness is more than just attesting to the seeing of something being discarded. It's a lot to do with attesting to the validity of the content as well as the volume. So again, those flybys, we might be able to see that on an overhead fisheye camera of someone coming in and out, but maybe they did actually see them draw it up and do all, and waste it appropriately, even though they're out the door. But on the flip side of that, well, if they just left the room, like how do you know that they actually did it right? And now in the documentation it says 2 people witnessed it. Well, my other witness was already gone, right? So how can we be sure from an evidence perspective that's really providing it? Technology can really help us do that. And so I think of it, Jeff and Marilyn and everyone listening, as like turning the lights on in a dark room. Before, you can't really see what's happening. You turn that light on and now pharmacy is getting clarity into the who, the what, the where, the when, and the why. Our compliance team is getting some legitimate and accurate documentation. So from a waste perspective, we're not worried about false documentation, because I'll just share with everyone, like if we're falsifying waste documentation, what else are we falsifying, right? And so we need to prove, not only for our patients, but for our staff. Think about technology as being something to help protect our staff against false suspicion. In my career, I think back in those cases of a suspicious drug diversion that still, I don't want to say haunt me, but still remain with me today that I've investigated are the ones where we had evidence of suspicion, we couldn't confirm it, and all of a sudden this person no longer wants to work at the organization. It degrades the culture and the trust of that person. But meanwhile, they never diverted, right? And so it's an icky place to be, and we need that level of visibility to truly secure waste from being an opportunity for diversion.
It's a great point. I know our friends at the Joint Commission have said if you can't control your own controlled substances, you can't control anything. So they start turning over every piece of paper, every
Sure.
rock, opening every filing cabinet. So it's a bad indicator of what's coming in those audits. Adam, when hospitals consider using technology to secure and verify drug waste, what are the key features or functions of the technology that truly make a difference in
Yeah.
establishing this missing accountability?
Yeah, and I like how you phrase it there, Jeff. Features, functionalities. We're not just talking about a tool. Like, this is not a product pitch. This is about like what has to happen. Like, how can technology support us? First and foremost, proof of action. Show me what you did. Show me the workflow. Prove it. Not only proving it to say that you did it, but hey, don't you want an alibi? Like, we need systems in place that create that objective timestamp evidence of what was wasted, who did it, under what conditions. Because I'll just be frank, in an investigation, it's what we're trying to do as investigators is think in our head, let's recreate the 3D rendering of that med room or that event just based on data. That's not good enough. We can't assume. We need verification of the workflow itself, and that's the proof that event actually happened. Now, I'm not saying that we're going to catch all diversion that way, but again, now that's one more element that we can completely set aside to say, we know what happened there. Now let's focus on everything else where the picture's a little blurry. So that's number one. The second thing I think about from that perspective is real-time visibility and more importantly, chain of custody. What I mean by that is we should never not know where drug waste is, right? It shouldn't live in a black box. It shouldn't be in the plane of like, oh, we only know what happened to it after the plane crashed, right? No, we want to know from point A to point Z where that drug waste is. And technology should be able to help with that. And not only should it be able to help with that, but more importantly, you heard me say chain of custody, Jeff. Why this is so important is because we don't know who in that paradigm of touching drugs could be diverting drugs. Why this is so important is because what I see and what I hear from a lot of my colleagues in the industry today is, well, we have processes around pharmacy picking up drug waste, pharmacies wasting it on behalf of anesthesia, so on and so forth. Every little pass off of drug waste is an opportunity for a new player to now steal drug waste. So if we don't have proper chain of custody and technology helping us connect those nodes to knowing that, hey, when that drug waste was captured from anesthesia, we brought it down to pharmacy. We need to know that the pharmacist or the tech didn't divert it in the process. And we need to be confident about that. So that's number two. Sorry, I get passionate about that one. The third one I think about is integration and usability. Technology is only as good as its ability to integrate what we already have, right? We don't want to completely change everything that we already have in place. Healthcare operations is a lot like our human biology. It's so complex. You remove one thing, it's like pulling a thread on a sweater. It never ends. So we're not trying to like recreate the wheel. We don't want to add extra burden to staff. We need to integrate this. Like, it has to this peg needs to fit perfectly into that workflow so that this is seamless and it's usable for our end users. And then the last thing I think about here, Jeff, is intelligence. When we think about how technology can help, AI is the buzzword, right? I think it's here to stay. We're all using it in all aspects of our lives, but we need it not to just record the waste. We need to analyze like what is happening in context of that waste. It's like a dance, right? Like, everything is in motion, and we need to know not only from, hey, did that happen? Sure, we can document it all day, but maybe that person documented it later or was lying about it. We need to know the context and everything around it, whether that's partial doses, late waste entries. We need this so diversion teams can really focus on where it matters most and not spend our time just trying to recreate that 3D rendering in our head. So I'll just finish with this. When we think about, when hospitals are thinking about technology, for waste accountability, it's less about the tool, as I mentioned, and it's more about creating that digital chain of trust. It's turning what has always been a manual assumptive-based process into one that is verifiable. It's visible, it's defensible. So there you have it.
You can have manual processes as long as there's verification and validation. And I think from all the time
Sure.
I spend in operating rooms, when they do sponge counts and instrument counts and needle counts at the end of the case, they do it
Yeah.
audibly and they do it visually in front of a witness to make sure that two people see exactly what's going on, that nothing was left in the body. And there's immediate verification at the time. That's a very
Yep.
manual thing that there's no way to change that. But the parallel is technology can do what they do manually in the operating room. Now,
Absolutely.
I want to talk about how you see this playing out in practice. When
Sure.
those proof points exist, it really changes how pharmacy and nursing teams collaborate during investigations and audits. Can you speak to that, please?
Yeah, no, you're right. It definitely has a huge impact. So again, when waste verification is supported by technology, it's not just to make documentation cleaner. It really changes the whole dynamic around accountability. You can see I'm visual with my hands because like diversion is nebulous. It's always a gray area. And so, we can't just think about one aspect when we think about drug diversion or drug waste. It's not just documenting the waste itself, right? So we need to understand the whole dynamic, the whole flux around how this is actually working all together. And so for one, Jeff, it gives pharmacy and nursing confidence that the data they're working with is accurate and defensible, right? That's first and foremost. We need the data to be right. And we can't spend our time chasing down missing witness signatures, trying to decipher, waste notes. Hey, what did you mean there? Why did you say that? Why didn't you just do this right the first time? We need to stop trying to figure out what actually happened hours after the fact, and we need evidence at the point of the time of when it actually happened. So that's number one, is accountability, building that confidence. Beyond that, I think about, and again, I've mentioned culture a lot. Like, I don't think that's by surprise. What we're talking about fundamentally changes the culture around this. And so traditionally, diversion programs have been reactive, and we could all argue that all day long about what reactive really means. But think about it. We start with a suspicion and we end with an investigation. That by nature, by definition, is reactive, right? So that can create a lot of tension between teams, right? But if we can verify waste in real time, now accountability is now proactive. It's not punitive. It's protecting staff just as much as it protects patients in the organization. And so oh, go ahead.
No, after you.
Oh, sure. Okay. And so I think that's an important distinction there, is that verification, I'm not claiming it means surveillance. In fact, it doesn't mean surveillance. It means transparency, right? So just let that sit in. Verification doesn't mean surveillance. It means transparency. So when everyone has access to the same objective record of what was wasted, it really removes a lot of that gray area in the emotion that I talked about, that nebulous flux of what's happening. And so from a culture perspective, instead of, pointing the finger and saying, hey, who messed up? Now the question becomes like pointed at all of us to say, how can we fix this process? Like, what can we fix in this process? So that shift really improves safety and trust at every level. And so, whether that's pharmacy, compliance, now they can focus their energy where it matters most, on those true anomalies or behavioral patterns that indicate risk, rather than sorting through all that noise. And at the same time, nursing, anesthesia, they feel less like they're being policed and more like they're part of a system that is providing them the safeguards they need to do their job, right? So the last thing I'll say here is all the meanwhile, leadership now has that demonstrable evidence that their diversion program isn't just compliant, they're credible. So the real why, Jeff, behind why all of this is bigger than just reducing diversion events is it's about creating a culture of verifiable accountability. This is one that protects patients. It's empowering our staff. It's strengthening the organization's overall safety posture, and it's better for our entire community.
It's really an important point, Adam, and it really bears repeating. Accountability does not have to feel punitive when
Yeah.
it's rooted in full transparency.
Yep.
Like you said, it's not surveillance, it's transparency, and that's a fundamental difference. In many ways, that's where inventory, technology, and culture begin to merge. When you connect the people, the processes, and the technology into a true closed loop system, and we're going to explore that next. This is where levers converge. It's a holistic approach. We've talked about the two levers, smarter inventory management and technology, but the real change comes when you link them together. When inventory management reduces the amount of waste transactions and the total volumes being wasted, and the technology validates what remains, the result is that closed loop. Fewer chances for diversion, stronger compliance, and safer staff and patients. Marilyn, why isn't it enough to just optimize supply or just add technology? What happens when you bring both of them together?
That is such an important question because in healthcare, we tend to focus on solving one side of the equation at a time. And when it comes to diversion prevention, that can leave major blind spots. If you only optimize supply, you might reduce how much waste you're generating, but you're not necessarily creating accountability for what's left behind. You still have manual processes, inconsistent documentation, and no real proof of how that waste was handled. And if you only add technology without addressing supply, you are verifying inefficiency. You're just digitizing the same inconsistent workflows that created the problem in the first place. But when those two levers come together, that's when things start to change. Inventory optimization reduces unnecessary waste, and technology ensures what remains is verifiable, traceable, and handled properly. It closes the loop. Culturally, that is a huge shift. It takes pressure off staff, it rebuilds trust between departments, and it moves the organization from a reactive posture, always chasing down missing documentation, to a proactive one, where waste is both minimized and managed with confidence. That's when diversion prevention really becomes sustainable.
Adam, what can you add to this?
Yeah, as Marilyn's speaking, I'm thinking internally around an analogy here. It's like we're trying to get this from both angles, and I was thinking about this like baking a cake. Inventory or optimization is like getting the ingredients right. Like you need your sugar, you need your flour, you need everything, you need the right drugs, the right doses, the right amounts. And then technology is a lot like your recipe that's bringing all of that together. It's telling you what supplies you need, what order you need to do it in. It's really guiding those ingredients that are incorporated in what order, right? So, but here's the thing, like even the best baker can't use a recipe correctly unless you have the right ingredients. So you can't get the result you want unless you have both. Like you need to come at this from both angles. And so what happens when hospitals unite those two levers is when you're getting efficiency and accountability, and they stop competing with one another and they start reinforcing and building upon one another. And so you're reducing the risk on one end and really proving that control on the other. And so I think that's really the foundation for a truly closed loop system. And everyone just keep in mind that when both of those levers are applied, it creates a synergistic effect, right? They're building on top of one another, and they have positive benefits beyond just reducing drug diversion. And you may have heard us speak to a lot of them today, but just to kind of recap some and mention some others, like think about the time saving for all staff, not just nurses having to find a witness, right, to waste if you had the right size drug and the right technology in place to make sure they can waste appropriately. But think about your your pharmacy team having to restock those pockets appropriately, right? So like everyone is involved in this. This is time savings for us. We're eliminating waste from even like a lean perspective, right? Think about staff satisfaction. A big complaint I always hear is like from a nursing perspective is like, are we going to get more alerts? Are we going to get more alerts on our ADC? Are we going to get more emails? Are we going to get more of this, more of that? We already put so much on our clinical staff. The last thing we want to do is add more alerts just to follow up on missing waste or documentation. And so again, if we can pinch both of these levers together, now that follow-up becomes a lot more streamlined and maybe less, right? Because there's less waste events and we have ability to follow up on these things instead of having to probe them and ask. A few more I think about compliance. again, from an inventory management perspective, you're reducing your risk for drug diversion from, if you're right sizing doses, waste is now one less thing, or you're reducing the capacity for them to divert waste in certain scenarios. But then from a record keeping perspective is how I really think about this. If you have the right technology documenting exactly what happened, you know for a fact that it's not falsified documentation, and your documentation is complete, right? Now you have a system of record there. And oh, by the way, like if you don't have to document waste, well, that's one less thing that you forget to do. I mentioned the patient and employee safety things. It's really the inverse of how I started this call. So if you think about needle stick infections, how substance abuse disorder can really impact both patients and employees, like it's the inverse of that, right? We want to create a safe system for our patients and our employees and everyone that we're caring for. The last thing I'll mention real quick, and we haven't mentioned it during this call, is being environmentally conscious. So if we're pinching from both sides and using both levers, we have technology that can segregate, our waste appropriately, so it's not getting into our waste, into our water streams. Like I'm a nut about water. Ask anyone on my team. I'm crazy about clean water. And so if we can actually make sure that things are wasted appropriately, have documentation for when EPA comes to site and say, oh yeah, you did waste that appropriately, but then also the lever of inventory management, let's reduce how much we're wasting so there's less risk of that going into our water streams.
Now, your food analogy was really great, and I think everyone listening can relate to that. What's really impressive is how that balance between ingredients and recipe actually shows up in real life in hospitals and everywhere except in my kitchen. When hospitals combine those two levers, inventory and technology, the resulting effects can be huge. Time savings, happier staff, stronger compliance, safer patient environments, and as you said, even more environmentally responsible waste practices. Marilyn, based on the gaps that you've seen in how hospitals manage inventory and drug waste, what kinds of improvements do you think are the most realistic when those two elements start working together the way they should?
Yeah, sure thing. So in my current work collaborating with hospitals, we've seen tremendous success in reducing controlled substance waste, such as greater than 80% or 90% reduction in their fentanyl and hydromorphone waste. However, there is still ways we cannot address through dose optimization because there are manufacturer-made products to meet every dose administered to patients. Controlled substances also encompass C5 to C2 and hot topic drug waste such as propofol waste. Personally, I would love to see more hospitals to leverage both smarter inventory management and technology to address the entire waste activity spectrum. Even though every hospital starting point is different, the outcomes are consistent. Fewer waste events, less waste volume, time savings, and stronger compliance.
Yeah, and Marilyn, and I know we're running up on time, we want to save a few minutes for Q&A if there is any, but I love that comment you just made. Outcomes are consistent. So, right, when we begin to pull on both those levers from an inventory management and technology perspective, we're not just fixing the problems right in front of us, we're building an infrastructure that allows for that consistent outcomes. And so leadership is gaining visibility into the near real-time future, and diversion teams can really focus their energy where it matters most instead of combing through all that noise. And so what I see is that organizations as a whole move from that reactive to a more proactive posture, spotting trends, reducing exposure, and continuously refining the process. And so it's that combination, really, operational efficiency, cultural trust, data-driven transparency that elevates diversion prevention from just a compliance task to a really true patient safety strategy.
It's a terrific perspective, Adam, and I think it really brings home how integrated diversion prevention needs to be across people and processes and technology. We've covered a lot of ground today in the last 55 minutes, from the risks around unmanaged waste to the tangible benefits of connecting these levers. We're sure that some of our attendees may have questions or even stories of their own about trying to tackle these same challenges. So let's open it up and hear what's on your minds. Adam, how do you suggest our attendees do that?
Well, if they haven't already, guys, the Q&A is open. You can ask your questions there. And we'll just give it a moment here to see what comes in. And any questions we don't get to, we're going to answer them anyways. If you put your name associated to asking the question there. Keep in mind, this is not a webinar to solicit products. So some questions we certainly can't answer on this call, but may require a subsequent follow-up call to answer some of those questions today.
And Jeff, it looks like there was one question that was put in the general chat during the discussion.
Well, let's take a look. Here's one. You talked, both of you, about the gray area between what's documented and what's actually verified. How can hospitals bring more transparency and real proof into that part of the diversion process without slowing down workflows? That sounds like, Adam, that's in your sweet spot.
Yeah, gray area. Let me think about this. Gray areas between what's documented and what's actually verified. So, as I think about how you're asking the question, Jeff, I think about gray areas existing because documentation is often treated as truth. I kind of mentioned that in the webinar, like we're just taking it as face value, but really in reality, it's just a reported activity. And what we really need to get towards and where technology it can help us do this is verification requires something different. We want that real transparency without slowing workflows, obviously, but we need to focus on passive verification. What I mean by that is like, we don't just need to add more documentation, like we need verifiable proof of what's happening. And so I think about, three things that we can really hone in on here, just top of mind. So one, if we need to be really tight about closing the gap between documentation and verification at the point of care. What I mean by that is we need validity or verification that if myself, Jeff, Marilyn, anyone on this call says you are wasting, says you're administering drug, whatever it is, we have verifiable proof that actually happened during that time. Because the second those two things begin to drift apart, that documentation and physical behavior, that's when risk starts to creep in. So whatever we can do to tighten that up. I think another really important thing to think about here, as you mentioned, the gray area, number two was the investigative logic. So we need to standardize what that is. And we need to, more importantly, have defined definitions behind what we mean by a verified resolution, right? Whether that's a undocumented waste event or a full-blown drug diversion investigation, how are we defining what verification actually means? And what evidence do we have to back that? So whatever that definition is, we need to get really standardized around that. And then the third thing I'm thinking about is really just shifting from signal review to workflow validation. What I mean by that is transparency comes more from validating the actual workflow steps, right? Like we can't just rely on signals. We need validation that it actually happened. So those three things. And so as I think about it, it's less about trying to fix a behavioral gap with more reporting. It's actually more about the reports today don't always provide the proof we need. A lot of times they just provide more noise, full transparency. And so I'll leave you with this, and we're just about at time. Transparency, in my mind, really happens when the system itself is reducing reliance on trust and replacing it with that verifiable step.
Terrific. I don't think we have a chance to get to some of the other questions, but again, if you want to send them to us, we'll be able to respond. Thanks to our panelists, Marilyn Wong and Adam Beeler. It was a pleasure working with you. To our attendees and participants, Fresenius Kabi and MIDAS Healthcare Solutions, thank you for joining us today, and we wish you a good rest of your day.
Thank you.
Thanks all.